Thank you, Manny, for the kind introduction. I also have to thank Mark. I didn't realize that Eve was a redhead. So actually further proving that the brunette is the mutation, not the red. So really appreciate that. So let's see. Okay. So today I'm going to talk to you a little bit about managing pregnant patients with chronic pain. And we're going to go over a little epidemiology. Really, I'm going to talk about the causes of chronic pain in pregnancy and the effects. And it's a little bit of a niche topic, you might say, but maybe not, because actually chronic pain is really common. More and more as we ask people, we realize that there are 25% of young adults, and in fact more women than men. So it turns out to be 37% of women between the ages of 20 and 44 report having chronic pain that impacts their daily lives. Now that kind of seemed like a lot to me, but when you think about it, how many of your friends really have back pain? Really, how many of them have a bad knee? It's not really all that uncommon. And of course, pregnancy is common. We have 4 million term pregnancies each year in the United States. So in reality, any chronic pain syndrome that occurs in young women can be superimposed on pregnancy. So if you do the math, you come up with 1.8 million pregnant women with chronic pain. So no matter where you work, you're going to be seeing these women. So what kind of pain issues are we talking about? So these are sort of the 4 most common. These are pain issues that cause more than 2 hours of lost productive time per week, so relatively impacting. The most common is headache. And you see that headache is very high until you get to sort of the menopause years. It's one of the few silver linings of menopause that it actually gets better. Then back pain. Back pain is the most common, pretty stable throughout those years. About 2% of women report back pain. And then you get arthritis. Arthritis, not surprisingly, gets worse as you get older. And then other. Comprising other is predominantly fibromyalgia and pelvic pain. So what kind of medicines are women taking? Women are taking a lot of medications. So these are women between 20 and 39 years, and these are the most common medications that you're taking. Not surprisingly, acetaminophen tops the list. Then we have codeine, diclofenac, ibuprofen. But not that far down there, you see in the red circles, we have morphine, sumatriptan, and tramadol. So you have these women who have chronic pain. They become pregnant. Well, what happens when they become pregnant? And it totally depends on what kind of chronic pain syndrome you're talking about. If you're talking about headache, it's kind of a good thing. Particularly migraine headache tends to get better. Autoimmune issues like autoimmune arthritis, multiple sclerosis, Crohn's disease. These things actually tend to improve during pregnancy, but many conditions get worse during pregnancy. Low back pain, 2% of young women have low back pain. Not surprisingly, with the hormonal changes that loosen the ligaments and the changing forces of gravity, 60% of women report low back pain during their pregnancy. 20% of them report pelvic girdle pain, and 50% of that pelvic girdle pain is going to be treated with some sort of medication. So you have a lot of women with chronic pain getting treated with medication. So what do you do about it? Well, it really depends on sort of where you're coming from. For the maternal fetal medicine doctor, it's really important to address it before the pregnancy occurs. And I talk about pre-treating, pre-optimization with PT and chronic pain consultation before a pregnancy is planned. Not always possible. In pain medicine, we deal with medical management. I've been doing a lot more ultrasound-guided interventions and also refer to pain PT. Pain psychology is very helpful as well, and of course, good collaboration with our MFMs. But most of you guys are anesthesiologists, so peripartum analgesia, really the key is to optimize regional analgesia, and the key is not to stop their peripartum medications. One of the biggest problems I've seen is patients who come in for planned surgery of whatever type is that, they're on high doses of chronic opioids and they're told to be MPO on the morning of surgery. well, why of all days is this the day for the woman to stop taking her normal opioids? It's kind of a setup for disaster. So I talked about pre-planning. Unfortunately, pre-planning doesn't always occur with pregnancy. This was a study of drug-abusing women, but in their non-drug-abusing control group, 50% of them had unplanned pregnancy. So whenever possible, preconceptual planning is important. And any woman of childbearing potential, this is something that I teach to our chronic pain fellows. Any young woman, you have to think about what drugs you're giving them, because a lot of the drugs we use are very toxic. So you have to give them that warning and ask them about what kind of birth control they're using. So what to do about chronic pain? In general, we talk about chronic pain as a biopsychosocial marker, biopsychosocial model. And when I talk about it to patients, I talk about management of chronic pain being a four-legged chair. The first leg that we're most comfortable with is medications. Second leg would be procedures that we can do. Third is physical therapy, and the fourth is pain psychology. I won't talk much more about pain psychology, but our psychologists can really be very helpful here, and they use tools such as biofeedback, cognitive behavioral therapy, and mindfulness meditation that can actually help women who want to avoid medications quite a bit. But I'm going to get really to the elephant in the room. What about all these drugs the women are on? Are they safe in pregnancy, and are they safe during lactation? So how do we know? First of all, what studies can we depend on, and how are these things studied? Of course, the gold standard is the double-blind randomized controlled trial, but these are almost never done in pregnancy. Can you imagine randomly assigning pregnant women to a drug and telling them that you just want to see whether they're going to have a birth defect or not? No one's going to sign up for that study. So what do? We use retrospective case control studies, basically where you compare pregnancies that did result in an infant with a birth defect, and you try your best to match them to pregnancies where there was a healthy infant. And parents are asked to remember back to whether they had an exposure to a particular drug. Well, the problem with that is there's huge recall bias, because you can imagine if you've had a child with a birth defect, you're thinking back, oh my God, did I ever take a Tylenol? What could I have possibly done? Was I sitting next to someone who was drinking a glass of wine? Might I have inhaled the fumes? There's huge recall bias, whereas if you've had a healthy infant, well, everything was good, so you're not really thinking about it. And then we have registry studies. And here, these are studies, and actually these are mandated now since 2015, when there was the labeling change by the FDA. Then they've actually mandated funding of registry studies where patients who need to take a drug that's not well known in pregnancy are actually enrolled in a registry, and the outcome of their pregnancy is followed, and the outcome of the child is followed during their early childhood years. And these are great studies, but the issue with these studies is that you have to have someone to think to enroll you in this study, right? So these are really only come from sort of tertiary care institutions. And most of our information comes from the really big database studies. This is where a large group, either a large insurer like Medicare, not so much pregnancy, but Medicaid in our country, Kaiser does a lot of these good studies. And in other countries where everyone is insured by the country, where they can see they can actually look at all of their patients. So what specific drugs might you be thinking about in pregnancy? First of all, there's huge variability in how many drugs that women take in pregnancy, and that makes me think that they can't all be critical. For instance, if you look at, this is France, Germany, Italy, and Norway. If you look in general at the black bars, France, they take an awful lot more drugs than Norwegian women. Are they sicker? Probably not. When you look at nervous, which is what opioids or pain medicine drugs would fall under, you see that French women take a lot of them, and German, Italian, and Norwegian women really don't. So there's huge variability. So I'm going to talk a little bit about opioids in particular. I'm going to talk about nonsteroidals. I'm I'm going to tell you what we know about acetaminophen, and then the antineuropathic drugs that we use in pain medicine. So first of all, opioid prescription. This is a slide from Brian Bateman and his group, just looking at opioid use in the United States during pregnancy. Again, huge variability and not really easily explainable. For instance, if you look at the state of Washington, up top is black, meaning more than 30% of pregnant women are prescribed opioids. That's really kind of a shocking number, no? If you look down, one state down, you see the state of Oregon, you see that 10 to 20%, so much lower. And then one state down, here we are in California. Actually, that was less than 10%. One state down here in California, we're 10 to 20. So it's hard to really explain that variability except maybe cultural acceptance of taking drugs during pregnancy. So what do we know about opioid use during pregnancy? This is one of those nice countrywide trials. This is done by Kalin, who's Norwegian. And he looked at the incidence of birth defects in women taking various opioids. And I've put in a black box, if you will, that's my next lecture, but opioids that are synthetic opioids, including tramadol and other synthetic opioids. This is the only instance where there are actually some evidence, although it's kind of weak, for increased risks of cardiovascular defects. In general, opioids, and particularly the non-synthetic opioids, are pretty clean. So at least we don't have to worry too much about birth defects. That's not to say that we don't have other worries like neonatal abstinence syndrome. And in terms of those neurodevelopmental changes, was it really the chicken or is it the egg? So is it really prenatal exposure that's associated with developmental delay? Or is it the infant being raised by the opiate-abusing mother that affects the environment? So in fact, this was a pretty interesting study where they looked at infants born to opiate-abusing mothers, and they compared the infants that stayed with the mother to infants that were fostered into non-opiate-abusing homes. And it turned out that the infants that were fostered didn't have any developmental delay. So in this case, it turns out it's probably the chicken. So the upshot of opiate prescription in pregnancy, I'd say avoid synthetic opioids. There is an increase of miscarriage if opioids are withdrawn in the first trimester. So if you need to stop opioids, probably waiting until the second trimester. There's also an increase in preterm birth if you withdraw opioids during the second trimester. So this is something that I commonly see as a pain management physician. I see a woman who didn't plan to get pregnant, who's on chronic opioids, and the question is, how do you help them come down and when? And the answer is that the best time is during the second trimester. Particularly avoid codeine. You probably all know this, but avoid codeine during lactation because codeine's a prodrug and there's very variable metabolism of codeine. So the amount of the peak is very variable from none. Some women will tell you they take codeine and nothing happens to them, to getting a very high, fast peak. And there have been neonatal deaths that have been attributed to fast metabolizing mothers breastfeeding infants. What about nonsteroidals and acetaminophen? This is another one of these big database studies from Scandinavia, and it has a number of these studies. And basically, acetaminophen seems to be pretty clean. Acetylsalicylic acid and other nonsteroidals, not so much. There's some cardiac septal defects, risk for cleft lip and palate. And of course, we know in the first trimester, when you use them, there's increased risk of miscarriage because of early placental abruption. So basically, acetaminophen are probably okay. For nonsteroidals, you have increased risk of miscarriage first trimester. Multiple studies have suggested a very small increase of risk for cardiac defects, and there's a risk of closure of the ductus in the third trimester. I don't quite know what to say about third trimester because now the obstetricians are starting to use indomethacin to prevent preterm labor, so I kind of leave that up to them to debate. So here's something kind of near and dear to my heart, migraine. Migraineurs in pregnancy, thankfully, a lot of them improve. 50% of them will improve during the first trimester and 75% by the second and third. So a lot of them who need medication, particularly the baseline prophylactic medications for migraine, actually can come off it during pregnancy, and that's normally what we recommend. On the other hand, 80% of them will have some migraines during pregnancy. And women who do have migraines during pregnancy tend to recur very quickly after childbirth. So one thing I would say is when you're seeing a patient postpartum and they report a postpartum headache, from first off, just assume it was your epidural catheter. You might ask them if they do have a history of migraines, and if they do, it's very likely to be a migraine. So history of migraines is associated with other pregnancy problems, interestingly, including preeclampsia, low birth weight, infants, ischemic stroke, MI, DVT, and PE. And it's really unknown what the mechanism of that association is, but it's something just to keep in the back of your mind if you have a patient who's a difficult migrainer and they're at increased risk for these bad outcomes. So migraine treatment during pregnancy, we try to advise patients to come off the prophylactic medications, particularly topiramate. Non-pharmacological treatments are really the best. There's good evidence for cognitive behavioral therapy, biofeedback, stress management. We really teach people about sleep hygiene. A lot of young women, myself when I was young included, were terrible about sleep hygiene. You get used to running 100 miles an hour and then you expect to come home and just fall asleep. It doesn't work like that anymore. Regular meals and also sort of mind-body treatments such as meditation and yoga are helpful at decreasing migraine incidence. Dietary, limiting caffeine, hydration, known food triggers. The good news is that the ablative drugs, triptans, are pretty clean. So the big database studies for triptans in pregnancy are pretty clean. So we feel comfortable prescribing triptans in pregnancy, particularly sumatriptan. The dietary supplements, I won't go through each of them. Nothing has randomized controlled trials, but there's some evidence for all of these things. This is actually the slide for the triptans. Most of the studies have been with sumatriptan just because it's the oldest and it's been around for the longest. So mostly we prescribe sumatriptan. It's not that there's any greater evidence. Interestingly, ondansetron is used often, and we feel so comfortable using ondansetron in pregnancy. But use in early pregnancy, there was a case control study recently that showed increased risk of clefts in women taking ondansetron. There are conflicting findings from 2 birth registries, but the jury's sort of out on that. That's just a little bit of a raised concern. One sort of bad actor in treatment for migraine is this butalbital that some women use. And this is really, it's a sort of god-awful drug made up of a lot of things, including barbiturates, caffeine, acetaminophen, and codeine. It's associated with medication overuse headaches and actually fatal withdrawal syndromes in the fetus. Historically, it was considered safe, but it's something we really don't recommend now. In terms of prophylactics, topiramate, there's a little bit of concern for. One thing that is, if you do need a prophylactic, one thing that's commonly used that's probably safe is propranolol. Beta blockers have been used for years in preeclampsia without any issues. And gabapentin is one thing that we commonly use, and a lot of big registries have come out recently, and it seems like gabapentin is pretty clean in pregnancy. There were some registries that came out years ago that just sort of lumped together all antineuropathic medications, and there were some concerns. But now that there are big studies that have pulled out gabapentin, particularly, it looks like gabapentin's okay. So the upshot for migraines is that triptans are likely safe. Best data is with sumatriptan. For migraine prophylactics, start out with the more familiar ones in pregnancy, like magnesium. A lot of people don't realize magnesium is a great prophylactic for migraine. It's something that you can take at bedtime. It's what are in a lot of the homeopathic sleep aids. You take it as 5 milligram pill. Also, beta blockers are probably safe in pregnancy. and big emphasis on lifestyle changes. Back pain in pregnancy, I saw a lot of the women kind of nod when I talked about the huge increase in back pain in pregnancy. 2% before, 60% after, super, super common. And postpartum, the prevalence is about 25%. And relapse rate is super high in pregnancy. So if you've had a woman, even if she's gotten better afterwards, really the key is pre-planning and core development. That being said, there are things that I've been doing lately in my clinic. I've been doing some sacroiliac injections for pelvic pain in pregnancy, which seems to be helpful. Back pain, risk factors, of course, are gaining weight, right? If you have increased weight, you're putting increased pressure on the poor discs of your back. I often, it's very hard to lose weight, but I often say to my chronic pain patients, think of yourself as carrying around a 20-pound backpack. Even if you lost 20 pounds, wouldn't it be great to put down that backpack? I think people can really identify with that. Of course, risk factors are also a history of low back pain, and of course, low job satisfaction. That just sort of gets into the environmental. If you're not really happy at your work and your back is hurting during pregnancy, it would be kind of nice to go out on disability because your back really does hurt. Etiology, you think about the increased lumbar lordosis that you have, and there's more inefficient neuromuscular control. Things that have been proven for management, interestingly, TENS devices are very useful. So often we'll tell patients, just go out to Walgreens and get a TENS device. And this is actually, in one study, was more helpful than exercise or acetaminophen. On the other hand, any kind of land-based exercise seems to help, and it's all about strengthening your core. So pain was about 50% in people who were doing a land-based exercise. Also, any sort of music-based relaxation. The interesting thing is there was no support in lots of studies for these pelvic support belts that you see women walking around with, the belly bands. No support for that at all. And this is just sort of a picture of the places where women get pelvic girdle pain. And unfortunately, exercise doesn't work for the pelvic girdle pain. And that kind of makes sense because you're not really talking about muscles. There's no muscle that you can strengthen to decrease the stress on these joints. So really, there's some evidence for acupuncture, and we've been going after with some injections, mostly local anesthetic and limited steroid. So as I said, the nice thing about injections for pregnancy is you can do them with ultrasound, and as ultrasound technology has gotten better, our ability to see and safely do injections, we even do some back and neck injections now with ultrasound instead of fluoroscopy. And so finally, when you get to the end of it, it's really a complex puzzle. There are a lot of medications, there are a lot of interventions. Many of them are safe in pregnancy. If you're not sure, it's really important to look it up. One message is that it's very patient-specific, it's very collaborative and multidisciplinary, and sort of good collaboration among the different disciplines is really the answer for your individual patient. With that, I'll hand over to my other Stanford colleagues who are monopolizing the session, and I thank you a lot for your attention. I'd be really happy to answer any questions. Thanks.